Hello guys, welcome back to the channel. It's Uche Kennedy bringing you everything USMLE. This video is going to mark the first in this series. You're going to see more of this kind of videos. And basically what these series of videos are going to be are demonstrations on how you should approach UWorld questions. You're going to see me interact with my students one-on-one in real time, and I'm going to be taking them through a few of their UWorld questions, and I'm going to be guiding them through interpreting these questions, and hopefully you're going to be able to learn and benefit from these videos as well. This first recording, however, I've not figured out the audio perfectly just yet, so you're going to have some echo when the student speaks, but please bear with me. Of course, I'm going to blow out my student's face, so you're not going to be seeing my student, but you're going to be hearing them as they answer questions and as they respond to my prompts. Of course, if you're new to the channel, please click the subscribe button. We are trying to get to 2,000 subscribers. I would really appreciate it if you subscribe to the channel. Give the video a thumbs up if you find this content helpful. Help us share to other medical students so that we can help them as well on this long USMLE journey. If you have any questions about anything in any of the videos, both this video or any other videos that I've made, please don't hesitate to ask me your questions. Leave a comment below, send me a message, send an email to studywithkennedy@gmail.com. If you want me to work with you one-on-one, send an email as well. Reach out to me on Instagram, anywhere. There are so many places you can find me. Send me a message and I will figure out a way to get you to your desired result. Okay, now that we've got that out of the way, enjoy. Okay, so you're thinking tamoxifen, raloxifene. For HER2/neu, you're thinking trastuzumab. For HER2/neu, you're thinking trastuzumab. You can see it right there.
Okay.
You can see it right there, right? Trastuzumab, anti-HER2/neu monoclonal antibody. You want to know that. How about P53 mutation? What if there's P53 mutation? What conditions can you think of associated with P53?
I know 53. That is tumor suppressor gene, so loss of function.
Okay. At least I like that you have a process to your thinking now. That is good. So do you have what is specific conditions? The number of them you can think of.
I know it's like they control from like G1 to S phase. So if there's a problem, like the G1 to S phase is gonna keep on going.
Uh,
Uh, cancer.
So even osteosarcoma, for example, osteosarcoma is associated with P53 gene mutation. As a matter of fact, with a lot of the things you're going to be seeing, a mutation in KRAS. I want you to learn this as a general principle. A mutation in KRAS will cause proliferation of growth in the tissue, and you're going to have things like hyperplasia and all of that. KRAS mutation will lead to proliferation and growth, adenoma. P53 mutation will result in carcinoma. So if we will probably see a lot of questions or a few questions on that here. But remember that KRAS mutation results in what? Rapid growth proliferation. Not necessarily cancer, adenomatous kind of things. P53 mutation will produce carcinoma. Do you get that? And then, of course, we said BCL2 is follicular lymphoma. You remember that from blood. All right, let's see the next one.
Oh,
All right, APC gene. When you think APC gene, what do you think about?
I think that's like colon cancer.
Colon cancer. You think of all the conditions associated with APC gene mutation. What comes to mind? Conditions associated with APC gene mutation.
Polyposis.
Okay, polyposis, familial adenomatous polyposis syndrome. Okay, do you remember the names of those syndromes?
No.
Peach-Jeghers syndrome, for example. When we get to GI, you're going to review them. So things like Peach-Jeghers syndrome, right? And Tocqueville syndrome, those guys. Okay, but we are not going to stress those too much. BRCA1, BRCA2, where do you see BRCA gene mutations?
Breast cancer.
Breast cancer. NF2. What's the meaning of NF2? What is NF?
Neurofibromatosis.
Neurofibromatosis. So you see this in what? Neurofibromatosis type 1, neurofibromatosis type 2. So NF1, NF2, right?
Yeah.
All right. Again, TP53 is P53. RB1 is what?
Retinoblastoma.
Retinoblastoma gene. All right. So look at this. 32-year-old woman. You got this right. What are they talking about here, and why did you pick D?
Uh, when I saw the when I saw osteosarcoma,
Huh.
and then I saw a genital tumor. So when I saw like a group of like tumors at once, like I kind of figured it was like P, I mean
P53.
P53.
So what's
Yeah.
this syndrome you're thinking about here?
Lymphomany.
Liframeni syndrome. Incredible. Excellent. Liframeni syndrome. Let's go. Okay, endothelial epithelial fibroblasts. I'm guessing this is asking you the site of origin of a particular cancer, right?
Yeah.
Okay, the origin of a particular cancer. Okay, so this is simple stuff. Let's see the first one you got wrong here. All right. So what happened here? Where do you see MSH1, MSH2 mutations?
Uh, Not sure.
Lynch syndrome, HMPCC. Do you remember HMPCC?
Huh. HNPCC. Yeah, I remember the name.
Okay. Hereditary HNPCC. I've forgotten the full meaning of HNPCC actually. Something I've forgotten the full meaning of that. But this is in relation to HNPCC here, right? MSH1, MSH2. This is associated high strongly with colon cancer, but alongside other cancers as well. And what you have here, the pathophysiology here is going to be microsatellite instability. You want to remember that phrase, microsatellite instability in relation to HMPCC gene mutation, MSH1, MSH2 gene mutation. Microsatellite instability. Do you get it?
Yeah.
Okay, so let's look at this and let's see why APC is wrong, because you can see a lot of people picked APC and you picked MSH2, so you are quite on the right track.
I picked APC.
Yeah, you are like you're thinking at least along the lines that most people would think about, which is good. I like to see it. 38-year-old man evaluated for bloody stools, weight loss, anemia. So once you see anemia in a man, what do you suspect? In a young
Uh,
man, first of all, anemia in a young man, generally speaking, what do you suspect?
like fatigue.
Yeah, like sign symptoms of anemia and stuff. Like, what do you suspect is the cause of the anemia in a young man? He's not
Uh,
menstruating, of course,
yeah.
and
Maybe
he
iron
does not have blood loss. Huh?
deficiency.
Iron deficiency. Why will a young man have iron deficiency? He's not menstruating, like we said.
Maybe he has like maybe he was born with like alpha thalassemia or something like that.
Okay, you can think of hereditary conditions, right? Maybe hereditary conditions. Okay, what else? I mean, a young man, 38, that has been normal all his life. So if you're not looking at hereditary here, you suspect peptic ulcer disease.
Okay.
That's the most common thing you're thinking about. Peptic ulcer disease, a young man. Now, if it's a man over the age of 50, what do you suspect? Or really even a woman over the age of 50, colon cancer. If you see iron deficiency anemia in a young male, peptic ulcer disease. In a young female, you can think of menstruation. They have more legit reasons why they should have iron deficiency anemia. In an older person over 50, a woman that's not menstruating, a man that's over 50, you start looking for colon cancer. Okay, when you look at bloody stool weight loss, once you see weight loss, always have high sense that there's malignancy somewhere, right? Sometimes it's not necessarily the case, but you should have a high index of suspicion for malignancy, especially on your exam. The patient's past medical history is unremarkable. He does not take any medications. He uses tobacco and drinks alcohol socially. His father died of colon cancer at the age of 40. Now, that should raise red flags for you, right? His father died of colon cancer at 40. That's very young. So what do you suspect? You start suspecting some form of hereditary condition. Now, this man is 38. He has blood in his stool. He has anemia. His father died at 40 from colon cancer. You start going boom. There's some hereditary situation going on here, something that affected his father, autosomal dominant inheritance, probably is affecting him as well. His younger sister suffers from endometrial cancer. So this is where you start deviating from the APC gene a little bit.
Mm.
Do you get it? This is where you
Mm.
start deviating from the APC gene a little bit. Now, Peutz syndrome is associated with breast cancer as well. Um, and other adenocarcinomas, right? So APC is kind of associated as well, but father at 40, sister with endometrial cancer, if you're not looking at Pujada syndrome, you kind of are living, you're going away from the APC territory, you're beginning to enter HMPCC MSH regions here. Does that make
Mm.
sense?
Yeah.
Colonoscopy shows a right-sided ulcerative colon mass. No polyps are noted. Now, that is important. No polyps are noted. They did not say that for nothing. In
Mm.
adenomatous polyposis syndrome, in the APCs, they usually generally originate from polyps.
Okay.
Do you see that? And I think that's what a lot of people missed as well. So the moment they go, no polyps are noted, you go, okay, right? And biopsy reveals adenocarcinoma, mutation of which of the following is responsible for the patient's condition. Again, very important what we said before. You interpret the question line by line. From this first statement, bloody stools, weight loss, anemia, we know okay, there is malignancy somewhere. He's losing blood for some reason. His past medical history is unremarkable. He does not take medications. Okay, that's general information, right? He
Mm.
uses tobacco drinks. Okay, father died of colon cancer at 40. Okay, now you're suspecting, okay, maybe something similar is going on in this patient as well. Younger sister suffers from endometrial cancer. Okay, maybe there is a syndrome running in the family, an autosomal dominant, perhaps, kind of
Mm.
syndrome that is probably contributing to him, both he having a condition and his sister probably having something similar. And you start thinking HMPCC, MSH already. There is minimal right-sided abdominal tenderness without guarding to deep palpation, right? So it's probably a right-sided mass. That's what I'm basically saying here, right? It's probably in the ascending colon. Colonoscopy shows right-sided ulcerative colon mass. Okay, so they just went ahead and told you, right? No polyps are noted, kind of helps you look away from APC for a little bit. Biopsy of the mass reveals adenocarcinoma, a mutation in which of the following genes is most likely responsible for this patient's condition. MSH2. Do you see that? All right, let's go.
So like, how do you like do all
Say that again.
like I was gonna come like doing it so fast in 1 minute?
How do I do it so fast in 1 minute?
Yeah, like coming under
Okay,
the.
so you're going to get faster as you get more comfortable and more familiar with the material, right? You can You can do it in 10 seconds. When you look at this question, you go bloody stool, weight loss, anemia, on the back of medical history, does not take medications, colon cancer, this, sister suffers from endometrial cancer, boom. You know your answer already. But it's experience, it's time, right? You're going to get it. You don't
Mm.
have to. 1 minute is a long time when you think of it. You realize that 1 minute is actually a long enough time. But you just have to go principled. Principled first. Once you get the principles down, your brain is used to doing it systematically. Then we are going to talk about working faster, right? But your performance on this block at least is better than all the other ones. So that is a good first step for me. All right. I was looking at other genes I saw there. Was that
Oh,
men
sorry.
one, men two? Where do you see men one?
Multiple endocrine neoplasia.
Multiple endocrine neoplasia, right? Okay. And VHL is for hyperlindau.
Yeah.
All right, let's go. Okay. What happens here? Read these vignettes and interpret. Let me hear your thought process.
A 72-year-old man comes to the office due to progressive weakness, fatigue, anorexia, and weight loss. So I'm thinking, this is like cancer symptoms,
Okay.
fatigue and weight loss over the past 4 months. He says that food doesn't taste as good. So I guess he lost his appetite and he feels only full after only a small amount. The patient has had a morning call for the past several years and streaks of blood in the sputum 2 weeks ago. So I'm thinking like he has something going on in the lungs.
Okay, so you're taking it in the lungs. Good. You
And
see, you're getting it right. You're doing it right. This is how you interpret. All right, go
he,
ahead.
he has a 50-pack year smoking history. So yeah, highly that's a risk factor for lung cancer. On examination, the patient appears frail with a sunken face and bitemporal wasting.
So bitemporal wasting is a very strong indicator for cachexia.
Weight loss, right?
Well,
Cachexia.
it's not just weight loss. People lose weight all the time. when you lose, when you see someone's head shrink over here by temporal wasting, like shrink in here, that is a very strong indicator for malignancy.
Mhm.
Right? People lose weight all over their body. You can lose weight, but you don't. It's very difficult to lose weight here,
Yeah.
to waste the temporalis muscle here.
Mm.
You get it?
Yeah.
So bitemporal wasting is a strong indicator for cachexia and malignancy. Probably HIV can produce that type of wasting as well. Okay, go ahead.
His arms are thin and notable muscle wasting. So it just confirms what we were saying. Lung examination reveals wheezing on the right side. So there's like bronchoconstriction on the right side. Chest
The mass
X-ray.
is probably on the right side,
Okay.
obstructed. So it's there's bronchoconstriction, that is correct. But it also means the mass is what is compressing and constricting,
Mm.
right?
A
All right.
check X-ray reveals a regular right perihilar mass.
What type of lung cancer do you think this would be based on the
Uh,
location? Just if you were to guess based off of the location. Irregular right perihilar mass. What kind of lung cancer is this?
I think the one squamous cell carcinoma,
Or
or I think there's another one indicating of smoking. Is it small? Is it small cell?
small. So the hilum is the central part of the lung. Central. So central squamous, small, central part
Oh,
of the lung, squamous cell cancer, small cell cancer. Both squamous and small cell cancers tend to be in the central part of the lung, perihilar. You get that? And they
yeah.
are strongly associated with smoking, unlike adenocarcinoma that is not necessarily associated with smoking. All right, which are the following the most likely contributing to this patient's muscle wasting? So they're asking you which of these is mediating his cachexia. And the correct answer there is TNF alpha, tumor necrosis factor alpha. Very, very important, right?
I thought
TNF.
I thought TNF alpha was just like for fever. Like, I think it causes fever, right?
Yeah, it plays a role in acute inflammation as well,
Okay.
right?
Oh,
It plays a role
okay.
in acute inflammation as well. So what you're having here with malignancy and stuff is almost like you have constant inflammatory process going on in the body, something of that nature, right?
Mm,
Constant inflammation. And TNF alpha is going to be causing death in some of the tumor cells as well, right? It's going to be trying to kill or whatever, anyhow you look at it, right?
mm, mm,
And what do I call it? As it's trying to shrink the tumor cells, it's also going to mediate the shrinking and apoptosis of normal cells, is the thing.
mm,
Because at the end of the day, the tumor cells are similar to our cells in a lot of ways. So whatever is capable of destroying the tumor cells is also capable of destroying other cells, which is why when you give people chemotherapy, you're going to destroy the cancer, but you're going to destroy actively dividing cells in the body, like the GI and the hair and all of that,
mm,
right? All right, but you want to know, whenever you think cachexia, you think what? TNF alpha. You think cachexia, you think TNF alpha. Where do we see calcium channel autoantibody?
I think that was Lambert Eden.
Lambert-Eaton syndrome, right? How do
Yeah.
those people present? How would you expect a person with Lambert-Eaton syndrome to present?
Um, uh,
How will a person with Lambert-Eaton syndrome present?
I think is that the one that pain with muscle use?
Is it pain?
Mm,
Lambert-Eaton is usually talked about alongside myasthenia gravis.
yeah, yeah.
Okay. What was the
Uh,
difference? With myasthenia gravis, you have muscle weakness.
Yeah.
And the muscle gets weaker and weaker with repetitive use.
Yeah.
With
Okay.
Lambert Eaton, you also have muscle weakness, but strength improves as you use the muscle,
Yeah. Yeah.
right? Strength
Yeah.
improves as you use the muscle. In myasthenia gravis, what was the pathophysiology? Antibody against what?
Acetylcholine.
Good. Antibodies against acetylcholine receptors. What type of receptor are those? Muscarinic or nicotinic?
Muscarinic.
No, nicotinic.
Um,
Autoantibodies against acetylcholine receptors, nicotinic acetylcholine receptors. And for Lambert Eaton, you have antibodies against what? Calcium channels. With Lambert Eaton, the strength is going to improve with repetitive movement. With myasthenia gravis, strength is going to decrease with repetitive movement. All right, interferon alpha. What do we use interferon alpha to treat?
I know interferon is used to like interfere with I think uh, well like bacteria trying to infect like it interferes with it.
Not really. We use interferon. Interferons do a number of things. There are different types of interferons, of course, and I need you to know what we use them to do. So interferon alpha. We use interferon alpha to treat liver hepatic cancer. No, not hepatic cancer. Liver cirrhosis. I might say. Okay,
Okay.
we use it in things like liver cirrhosis.
Okay.
Okay,
Yeah.
interferon alpha will be useful in liver cirrhosis. Give me 1 second. I'm thinking of something here. Okay, in liver cirrhosis, I think they also have application in bacillary angiomatosis. Is it bacillary angiomatosis? I think so. They have used in bacillary angiomatosis Kaposi sarcoma. Interferon alpha can also have a role in Kaposi sarcoma. Interferon beta you'd use in multiple sclerosis. Interferon beta in multiple sclerosis.
The treater, right?
Yes.
Okay. Okay.
There are other medications, of course. You just want to know. Interferon beta in multiple sclerosis, and interferon gamma for chronic granulomatous disease. Why? Interferon gamma activates macrophages. Interferon gamma in chronic granulomatous disease, you see this when we get to immunology. But interferon gamma activates macrophages. You want to know that. Interferon gamma activates macrophages,
Mhm.
right?
Yeah. And
All
you said,
right.
sorry, interferon alpha is used to treat liver cirrhosis and Kaposi sarcoma,
Kaposi
right?
sarcoma, bacillary angiomatosis, and a wide range of tumors actually. They are not limited, it's not limited to the ones we've mentioned at all. Right?
Yeah. Okay.
And interferon gamma for chronic granulomatous disease.
Yeah.
When you think TGF beta, what comes to mind?
Um.
If I asked you to give me one role of TGF beta,
Thinking um like it's for like blood vessels, making blood vessels.
for making blood vessels, what do you mean by making blood vessels?
Like if there's like a if like you have like let's say like for example you have a overgrowth or fiber is gonna add like blood vessels supply to the
Okay, I want you to remember TGF beta and its role in fibrosis. It plays a role in fibrosis. It plays a role in apoptosis. Fibrosis, apoptosis. It also plays a role in the cell cycle, but I would let that be for now. Okay. Fibrosis, apoptosis. All right, let's go. And then vasopressin is ADH, right?
Oh yeah, that's for like water reabsorption, right?
Water reabsorption. And
When
what are those channels that reabsorb the water? What do we call them? Do you remember them?
aquaport,
Aquaporin channels. Great. Okay, let's go.
uh, a
Okay.
4-year-old, okay.
Yes, go ahead. Interpret.
A 4-year-old boy is brought to the emergency department for difficulty breathing and a productive cough. So this could be with the lungs, could be pneumonia. You know, he has a past medical history of recurrent episodes of sinusitis and otitis media. So respiratory infections typically have a
No,
protracted.
no, no, no. That's second line. Do you think you've done it justice? He has a past
Oh,
medical history of recurrent episodes of sinusitis and otitis media. What do you think?
so I'm thinking like maybe he could be immunocompromised
Good.
or
You begin to wonder, why is he having recurrent? People don't just have recurrent sinusitis and otitis media just like that. So you have to wonder, why is he having recurrent episodes of sinusitis and otitis media? Do you see that? That's a
yeah,
valid question that has to be asked. And then you said, okay, maybe he's immunocompromised. Exactly. You go ahead then.
respiratory infections typically have a protracted course
Mhm.
but respond to high dose antibiotic therapy. So I'm thinking it could be like a bacterial or a
We
virus.
probably don't. It could be bacterial, given the recurrent episodes of sinusitis and otitis media. He's immunocompromised in such a way that he's having recurrent, seemingly bacterial infection. But here they told you that the infections usually have a protracted course, so they usually last a bit,
Oh,
right? That's what
protract.
a protracted course means. They last quite long and
Oh,
they're
okay.
difficult to manage, but they respond to high dose antibiotic therapy.
Oh.
Okay, go ahead.
Pulmonary auscultation shows crackles and wheezing, so that means there's fluid in the lungs. And
Okay.
then wheezing, there's also like bronchoconstriction as well. Cardiovascular examination shows a cardiac point of maximal impulse that is palpated at the right fifth intercostal space. So I'm not sure what that's supposed to.
No, so you're not sure because you're thinking of it in your head. Locate the right fifth intercostal space on your body and tell me what you feel. The right fifth intercostal space. Is anything off? Do you notice anything off? Your fifth intercostal space should be somewhere around your nipple. So the right fifth intercostal space is where they are noticing his cardiac impulse. He said, do you notice anything weird?
Oh, that's the heart is on the wrong side.
Good. You see that? So when you just read it like that, you just read it. Okay, you're just reading it. Sometimes when you're not sure of what you're reading, you want to take it off of just thinking about it in your head and say, wait a second, right? 15 intercostal space. No, something is wrong. It's supposed to be on the left side. Why is his 15 intercostal? Why is his point of maximum impulse on the right? So what do we call this?
Cardiogenic syndrome.
The Jenner syndrome. Dextrocardia.
Yeah.
Seen in primary ciliary dysmotility. So you see, if you had done that, you might have gotten this question correct.
Yeah. I was thinking cystic fibrosis.
Yes, but yeah, cystic fibrosis would present very similar to this, but them saying the point of maximum impulse is palpated at the right fifth intercostal space. Whenever they describe something that is a location on the body and you're not clear what it is, then try to locate it on your own self and maybe you figure out what is off about it. And right there, Cartagena syndrome or primary ciliary dysmotility and Dining arms is the big deal, right?
Yeah.
Do you remember the other arm? We have kinesin and Dinin. And those are the guys that play a role in transport, right? Kinesin and Dinin are the guys that play a role in transport of substances
Yeah. I think
along.
dining is backward and kinesin is forward.
Good. So what do we call that? What do we call that? Backward movement or forward movement? The forward is
Retro. I
no
mean,
anterograde. Anterior. The forward movement is anterograde. So kinesin is anterograde. Denine is retrograde. Why is that important? When people get infected with viruses, say rabies, for example, when people get infected with something like rabies, for example, how does the infection enter the central nervous system? Is it anterograde or retrograde?
I think it's retrograde.
Retrograde. Retrograde. Because it enters from the bottom part or the tail of the neuron and travels up to the head of the neuron. So when people get primary infection with herpes, this is where I wanted us to land. When people get primary infection with something like herpes virus, it enters via retrograde transport. But you will remember that we have reactivation of some of these infections, reactivation of herpes, varicella, whatever. How does the reactivation occur? What type of transport is involved in the reactivation? Anterograde. Now the virus is traveling out of the neuron via the tail. So primary infection, retrograde transport with what? Denine arms.
Yeah.
Reactivation, anterograde transport with kinesin. You get that?
Yeah.
Anterograde transport with kinesin. What disease do you remember that is associated with C1 estrase deficiency? A problem with C1 estrase deficiency. So when you're reviewing, this is what I want you to be doing. You want to be asking for each of those options, not just go and read the explanation. You have to ask yourself what is going on here. So what disease is associated with C1 estrase deficiency?
Maybe like has to do maybe complement.
Yeah,
Uh,
C1 is it's complement. That's what we are talking about here. This is complement by default. So what disease is that? Hereditary angioedema. Okay,
oh,
that would be hereditary angioedema. Hereditary angioedema. That would be hereditary angioedema, right?
yeah.
All right. What condition, disease is also associated with a deficiency in early complement? So C1q, C2, C3, C4. What disease is that? So we already saw hereditary angioedema with C1 estrase deficiency. What disease is associated with early complement deficiencies? C1q, C2, C4. What disease is that? That would be
Is
SLE.
it SLE?
Yes, that would be SLE. So SLE is associated with early complement deficiencies. Early complement deficiencies. How about C5 to C9? What condition is associated with C5 to C9 deficiency? What condition is associated with C5 to C9 deficiency? What would that be? Remember, C5 to C9 is called membrane attack complex.
Yeah, Mac.
Good. What condition is associated with it? Remember that people with C5 to C9 deficiency will be prone to recurrent Neisseria infections. Right? They'll be prone to Neisseria infection. Neisseria meningitis, Neisseria gonorrhea, right? Neisseria infection, Neisseria bacterial infections. What medication will also cause angioedema? Just like you have a C1 estrase deficiency, what medication will also
Oh,
cause angioedema?
um, and ACE inhibitors.
ACE inhibitors. Very good. ACE inhibitors. When you think of chloride channels, what medication comes to mind or medications? Chloride channels. There are a set of medications. One of them increase the frequency of opening of chloride channels, and the
Oh,
other increase the duration of opening.
benzodiazepines and barbiturates.
Benzodiazepines and barbiturates. So benzodiazepines increase the frequency of opening of chloride channels, and diazepines. Barbiturates increase the
Yeah.
duration of opening of chloride channels. And then, of course, we've seen the NIN arms, right? Associated with Cartagena syndrome, primary ciliary dysmotility. In interleukin 2 receptors, we have a bunch of medications that inhibit interleukin 2, right? Interleukin 2 plays an important role on T cell replication, right? You remember your cyclosporine, tacrolimus, sirolimus, all of these medications were targeting interleukin 2. Do you remember that?
Those are the ones that's nephrotoxic, right?
Yeah,
Okay. So
immunosuppressive agents.
okay.
Okay, and then we have NADPH oxidase. What does that enzyme do? What does NADPH oxidase deficiency cause?
Is it is it G6PD?
No,
No.
G6PD deficiency is G6PD deficiency, right? G6PD deficiency is G6PD deficiency.
Yeah. Oh, and it's an NADPH oxidase. That um that's for encapsulated organisms.
You're very close now.
NADPH oxidase.
Give me 1 second here. Yeah, go ahead. We actually talked about it today already, so if that's a clue. That'll be chronic granulomatous disease.
Yeah.
That'll be chronic granulomatous disease. All right. So when you review a question like this one, you walk through it. It takes a while, but you can easily go through the options, ask yourself, instead of just going to read everything they just wrote, read it, read it, read it. You should read what they wrote, but you want to also talk to yourself a little bit about all of these things, right? All right, let's go.
A 13-year-old boy is admitted to the hospital due to fever and fatigue for the past week. So it could be anemia. The patient received
It could be what?
anemia.
No. Why is anemia wrong?
Oh, sorry, not I saw. I was fatigued. No, fever. Sorry, it could be infection.
Probably an infection. Okay.
The patient recently received a cadaveric renal transplant for glomerulonephritis. So he could be immunosuppressed because they're gonna give him immunosuppressive medication when you're doing the transplant.
Very good.
And his immunosuppressive medication regimen was increased a month ago due to early evidence of rejection. So they gave him a high dose.
Mhm.
Uh, uh, temperature is 99.9. I guess that's a low grade fever, right? Heart and lung examination are unremarkable. The liver is mildly enlarged, and the spleen is. So this is called hepatosplenomegaly. There is notable adenopathy of the bilateral, inguinal, and axillary regions. So like he has like lymph node,
When there's
like
infection, you often get lymphadenopathy.
yeah.
Okay.
A CBC shows mild leukopenia, so he has a low white blood cells, which could mean like bone marrow suppression. Histopathology findings from biopsy of one of the enlarged lymph nodes are shown in the image below.
Okay. No. Don't go to the okay. I don't want us to look at the options. But so I was going to ask you, what type of infection is this? Now, when someone has fever and fatigue for a whole week, what is the likelihood it is a bacterial infection? Pretty low. it is less likely that it is a bacterial infection. Do you get it?
Yeah.
Fever and fatigue for a whole week, you start thinking of viral infection, especially when you have low-grade fever. Low-grade fever, you start thinking towards viral infections as well. Bacterial infections will just cause fever, most of the time, especially on your exam. Low-grade fever, you can start thinking of viral infection. Low-grade fever that has lasted a whole week, probably really, really viral infection. There are some severe bacterial infections that can cause fever lasting over a couple days, like if there's an abscess, for example, right? And stuff like that. Okay, if there's an abscess, yeah, that makes sense, right? But other than that, when you really have low-grade fever for a whole week, you should be looking more towards viral infection. And in this case, I was going to ask you what virus it's going to be, but we already looked at the explanation or the answer. So it's supposed to be EBV here. And go to the explanation. I think they will label this image for you. You're going to see a typical T cells. Yes, this is or B cells rather. Diffuse large B cell lymphoma. I didn't necessarily see that he had diffuse large B cell lymphoma, but what you're going to see are atypical B cells, okay, in EBV infection, atypical B cells, and that's what they're showing in that image. In this case, they're saying that the child has developed B cell lymphoma, which is also possible, but it could have also just been an EBV infection, right? The point here is that the B cells are not looking normal. B cells are supposed to be dark blue, completely dark blue and small. Remember the way T cells and B cells look in histology? They're small, 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 small dots.
Mm.
Do you get it?
Mhm.
They are usually tiny blue dots on histology, but here you see them large. They're atypical B cells. Do you get that? All right.
So when we, so what pointed you to like EBV? Oh, the hepatosplenomegaly.
Hepatosplenomegaly, inguinal adenopathy, and the image. Look at this image, kind of make a mental note of what it looks like. There's nothing to look for specifically, but just kind of have an idea what you're looking at here. You see the pattern, when you see it again, you start noticing the pattern. So immediately I saw this image, I knew, okay, it's EBV. But it's not like something I can just show you right away, right? All right. And then you go to the option, look at the options they gave you. EBV and parvovirus are literally the only viruses there. And parvovirus will produce slapped cheeks disease. If you remember, slapped cheeks, it will cause bone marrow suppression, red cell aplasia, stuff like that. So this is not parvovirus. So the only other thing is EBV. All right, great.